I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. It's time for another episode of Evidence with Anne, where we take the RANZCOG landmark trials and transform long, complicated journal articles into soundbite summaries that you can listen to on double time on the way to your exam. Today, we're going to discuss some of the gynaecology trials, those relating to early pregnancy. We'll first discuss those trials relating to recurrent miscarriage, aspirin and low molecular weight heparin, the SPIN and ALIFE trials. Then we'll discuss a 2005 trial comparing misoprostol and surgery for the management of miscarriage. Let's get into it. We'll start with the SPIN trial.
As usual, we'll cover the essentials: title, author, year, and journal. The SPIN trial, or its full name, Scottish Pregnancy Intervention SPIN study, a multi-centre randomised control trial of low molecular weight heparin and low-dose aspirin in women with recurrent miscarriage. It was published in 2010. It was published by Clark et al. In the American Society of Haematology.
The aim of the SPIN trial was to assess whether treatment with enoxaparin and low-dose aspirin, alongside intensive pregnancy surveillance, reduced the rates of pregnancy loss in those with recurrent miscarriage. The trial design was a parallel group, multi-centre, randomised controlled trial. The 294 participants included those with 2 or more previous consecutive pregnancy losses at less than 24 weeks gestation and who were currently pregnant at less than 7 weeks gestation. These women were randomised to 40 milligrams of enoxaparin and 75 milligrams of aspirin daily, alongside intense pregnancy surveillance or intense pregnancy surveillance alone. It was a multi-centre study conducted in Scotland, England, and New Zealand.
Right, so what does intense pregnancy surveillance mean?
Intense pregnancy surveillance included an ultrasound every 2 weeks from the diagnosis of the pregnancy until 12 weeks, and then 4 weekly until 28 weeks. In this study, the exclusion criteria essentially included anything that might explain the cause of recurrent miscarriage, such as evidence of anatomic, endocrine, chromosomal, or immunologic abnormalities in a previous pregnancy loss, a history of venous or arterial thrombosis, antiphospholipid syndrome or antiphospholipid antibodies at enrollment, a thrombotic disorder, or any condition that precluded the use of aspirin or enoxaparin, for example, low platelets.
All right, I think I need a summary so I can imprint this information into my brain.
Okay, the SPIN study is called the Scottish Pregnancy Intervention Study, a multi-centre randomised controlled trial of low molecular weight heparin and low-dose aspirin in women with recurrent miscarriage. It was published by Clark et al. In 2010 in the Journal of the American Society of Haematology.
It randomised 294 women with 2 or more consecutive miscarriages who were less than 7 weeks gestation to aspirin, low molecular weight heparin and intense pregnancy surveillance, or intense pregnancy surveillance alone.
The primary outcome was the pregnancy loss rate. The secondary outcomes included the tolerance and safety of enoxaparin and aspirin.
And the analysis was intention to treat. A chi-squared analysis was used for pregnancy failure rates.
Mel, I'm guessing from our recurrent miscarriage episode that the enoxaparin and aspirin didn't help.
That's right. So there was actually no difference in the pregnancy loss rates between the two groups. The absolute rates were 22% versus 20% in the intervention and control groups respectively. The odds ratio, for those who love the numbers, was 0.91 with a confidence interval of 0.51 to 1.59 and a p-value of 0.85.
There are a few features of this article that I wanted to bring to your attention. First, the definition for recurrent pregnancy loss used in this study was 2 or more consecutive losses. I guess the definition of recurrent pregnancy loss does vary for different guidelines, so it's important to keep this in mind. Next, there was no blinding and there was no placebo in this randomized trial. And because of slow recruitment and funding limitations, the required sample size was not achieved. Lastly, because the patients were recruited if they were 7 weeks or less, it's possible that if there was effect of these medications with implantation, then this would not be captured in this study.
Okay, so in summary, in those with a history of recurrent miscarriage, the SPIN trial did not demonstrate a difference in the pregnancy loss rate if treated with aspirin and low molecular weight heparin alongside intense pregnancy surveillance versus intense pregnancy surveillance alone.
Fabulous. So now we have another trial about recurrent miscarriage, and take it away.
The ALIFE trial was written by Carla et al., published in 2010 in the New England Journal of Medicine. Its full name is aspirin plus heparin or aspirin alone in women with recurrent miscarriage, or ALIFE stands for anticoagulants for living fetuses. It was a randomized trial, the aim of which was to investigate whether aspirin combined with low molecular weight heparin or aspirin alone as compared with placebo improves live birth rates among women with recurrent pregnancy loss.
The participants included 364 women between the ages of 18 to 42 with a history of unexplained miscarriage and were attempting to conceive or were less than 6 weeks pregnant. They were randomized to 80 milligrams of aspirin and 2,850 international units of nadroparin, 80 milligrams of aspirin alone, or placebo to start as soon as a viable pregnancy was demonstrated.
What did this study use as the definition of recurrent pregnancy loss?
So this study used a definition of 2 or more clinical miscarriages, which meant a positive pregnancy test and clinical manifestations of miscarriage. As part of the inclusion criteria, both partners needed a normal carrier type, no uterine disease, and no antiphospholipid syndrome. The exclusion criteria included a biochemical pregnancy, previous arterial or venous thromboembolism, another indication for low molecular weight heparin, or endocrine disorders.
The primary outcome in this one was the live birth rate. Secondary outcomes included the rates of miscarriage, obstetrical complications, maternal and fetal adverse effects, and intrauterine fetal death. The analysis was intention to treat. Differences were analysed by Fisher's exact test, or chi-squared, and differences in live birth rates were expressed as absolute or relative risks with 95% confidence intervals.
Okay, enough statistics. Let's talk results. Of the 364 participants, 299 became pregnant. Live birth rates were 69.1% in the heparin and aspirin group, 61.6% in the aspirin group alone, and 67% in the placebo group. So there was no difference between the 3 groups. There was no improvement in live birth rates.
In the ALIFE trial versus the SPIN trial, a placebo was used. However, it was only used for the aspirin, not the heparin. And similarly to the SPIN trial, the study did not reach sample size required.
So let's summarise. The ALIFE trial, anticoagulants for the living fetus, otherwise known as aspirin plus heparin or aspirin alone in women with recurrent miscarriage, was published in the New England Journal of Medicine. The author was Carla and it was published in 2010. The aim was to investigate whether aspirin combined with low molecular weight heparin or aspirin alone as compared with placebo improves live birth rates among women with recurrent pregnancy loss. It was set in 2004 to 2008 in 8 hospitals in the Netherlands. Participants included 364 women between the ages of 18 to 42 with a history of unexplained recurrent miscarriage who were attempting to conceive or who were under 6 weeks gestation. They were randomized to 80 milligrams of aspirin plus nadroparin, 80 milligrams of aspirin alone, or placebo to start as soon as a viable pregnancy was demonstrated.
299 of the participants became pregnant. Live birth rates were 69.1%, 61.6%, and 67% between the 3 groups, so there was no difference in live birth rates between the 3 groups.
Now we've covered the trials on recurrent miscarriage, let's discuss the RANZCOG landmark trial regarding the management of miscarriage. Carla, your turn. Take it away.
So, titled A Comparison of Medical Management with Misoprostol and Surgical Management for Early Pregnancy Failure. It was published in the New England Journal of Medicine by Zhang et al. In 2005. The aim of this study was to assess the efficacy, safety, and acceptability of misoprostol for use in the treatment of failed pregnancy in the first trimester. It was a multi-centered trial in the USA set in 2002 to 2004.
I'm kind of sad this trial doesn't have a nice little acronym to remember it by.
Yeah, I know. You just have to know the whole title.
I know. So this trial randomized 652 women with a first trimester pregnancy failure to either misoprostol or surgery in a 3-to-1 ratio. 491 women were randomized to the misoprostol arm. They were given 800 micrograms of miso vaginally on day 1 and day 3. If there was incomplete evacuation after medical management, then surgical management was offered on day 8. Failure on ultrasound at day 8 was defined as an endometrial thickness of greater than 30 millimeters.
What did the study choose for a definition of first trimester pregnancy failure?
Some of the terms they used for inclusion in first trimester pregnancy failure we don't tend to use anymore. They included anembryonic gestation, embryonic or fetal death, or incomplete or inevitable spontaneous abortion.
And who did they exclude?
They excluded patients with anemia, which was defined as a hemoglobin under 95, hemodynamic instability, a clotting disorder, if they were on anticoagulants, or if they had an allergy to prostaglandins or NSAIDs.
The primary outcome for this study was treatment failure, as defined by surgical treatment or repeated suction aspiration within 30 days after the initial treatment. This was a non-inferiority trial. Now, what we've all been waiting for, the results. In the misoprostol group, 71% had a complete expulsion by day 3 and 84% by day 8, with a 95% confidence interval of 81 to 87%. Thus, in the misoprostol group, there was a 16% treatment failure. The treatment failure in the surgical group was 3%. The researchers also asked the study participants about their treatment. 78% in the misoprostol group said they would use it again, and 83% said they would recommend it to others. The side effects were more common in the misoprostol group, and there was no difference between the groups for hemorrhage or pelvic infection, which was less than 1%. There was no significant difference between the two groups for unscheduled visits to the hospital, which was 23% in the miso group and 17% in the surgical management group.
Wait. Back it up. What do you mean by a non-inferiority trial?
Essentially, a non-inferiority trial investigates whether one treatment is not worse than an existing treatment. So in this case, they were testing if miso is not worse than surgical management. Because it was a non-inferiority trial, not a randomized trial, there was no expectant management group.
Interesting. So summary time. Let's keep going with this repetition. So this trial was called A Comparison of Medical Management with Misoprostol and Surgical Management for Early Pregnancy Failure and was published by Zhang et al. In 2005 in the New England Journal of Medicine. It randomized 652 women with a first trimester pregnancy failure to either misoprostol or surgical evacuation with a 3-to-1 ratio, and it was a non-inferiority trial.
The primary outcome was treatment failure. Treatment failure in the misoprostol group was 16% and 3% in the surgical group. 78% of those in the misoprostol group said they would use it again. 83% of those in the miso group said that they would recommend it to others. Hemorrhage and pelvic infection was less than 1% in both groups. Unscheduled visits to the hospital were 23% versus 17% in the miso versus surgical groups, and side effects were more common in the miso group. In summary, treatment of early pregnancy failure with 800 micrograms of misoprostol vaginally is safe and acceptable.
Okay, so I just wanted to share a couple of tidbits on how to remember the recurrent miscarriage trials. So they were both published in 2010. The SPIN trial looked at pregnancy failure rates as their primary outcome, whereas the ALIFE trial, as mentioned in their name, looked at live birth rates as their primary outcome. Anyway, now before we go, I wanted to briefly discuss the MIFI-MISO trial. This is not currently on the list of RANZCOG landmark trials. The full name of this trial is mifepristone and misoprostol versus misoprostol alone for the management of miscarriage, or MIFI-MISO, a randomized double-blind placebo-controlled trial. This trial was published in 2020 in The Lancet. It randomized over 2,500 women to, you guessed it, either mifepristone and miso or placebo and miso. If you've been working over the last few years, you may have noticed a difference in practice with regards to the medical management of miscarriage. Of those in the MIFI-MISO group, 17% did not pass the gestational sac spontaneously within 7 days. That's versus 24% in the placebo-MISO group. And of those requiring surgical intervention, 17% of those in the MIFI-MISO group versus 25% in the placebo-MISO group. The conclusion from this study was that it demonstrated that treatment with mifepristone as well as misoprostol was more effective than misoprostol alone for the medical management of miscarriage.
Oh, that makes so much sense, especially in the timing of things changing. And now you don't need to be a registered MS two-step provider to prescribe it to patients, which might make it more accessible for those who want to use this for the management of miscarriage. Although the educational package is really good too.
Well, I hope this has helped make the RANZCOG landmark trials a bit more manageable. Thanks for that, Anne. So thanks for listening to the Uterine Sound podcast. Check us out on Instagram at the Uterine Sound or via email, theuterinesound@gmail.com, or you can also find us on our website, www.theuterinesound.com. Let us know if you have any questions, queries, or if you just want to fact check us.